This is the final of the three parts in which we discuss the Lego network. And in this part, we will briefly show the initial 2-year results and discuss some future goals. The network started in October 2011, and for the first 3 months, we focused on training, which was done in a variety of situations, large groups where we explained the data, a lot focus on the acquisition of the echo images for the neonatologists and ways of getting the portable echo machine and transferring the images. We visited maternities, we were together with the nurses. It was a large plan to train the team. During the first 3 months also, we acquired all the equipment, which were the pulse oximeters, the tablets that shows, and the portable echoes, and distributed them to the maternities. And between January 2012 and December 2013, we managed to screen over 41,000 children with pulse oximeter and clinical screening. Did over 1,000 level 2 screenings with the echoes done by the neonatologists. Nearly half of those were neonates with heart conditions. Did a few actions to screen all the children. Did a number of outpatient clinics and cardiac echoes on children known to have cardiac conditions, and to do 6 operations. Briefly about the screening. You see here, this is the clinical and pulse oximeter screening, with some variabilities which we believe are to do with birth rate, but mostly stable. In January, it was only a test, a few maternities, and from February, all joined. But when we look at the echoes, the pulse oximeters, and the altered physical examinations, we see that there are a few discrepancies. This is after a course in which we discussed a lot about palpating peripheral pulses. Many babies with suggestion of coarctations. We were missing coarctations in the beginning, and then it seemed to have come down. Pulse oximetry also has started with a number of false positives. We managed to bring this down, and this is the number of echoes that have been done by the neonatologists. We were very worried with some unexpected findings with pulse oximetry, and really what we found was that, to start with, not all equipment was adequate for the very, very small tolls of neonates. That led to many false negative results. The overloaded clinical scenarios led to a very slow incorporation of the protocols. There were many children being discharged home with abnormal findings. There were many abnormal parts that were not repeated, and the time between doing the exam and typing it into the system was also very long, which again led to discharges of babies without further evaluation. And local changes in nursing staff was another worry, because new nurses would be brought in and with no training start doing the test, and then again the false results would increase. So as the model is constantly being adjusted, we moved on to change the equipment when that was the problem. We introduced typists, and that really helped a lot with the time between the exam and the set of data being entered in the database. But above all, we introduced a database system alarm that whenever a saturation below 95 is entered into the system, or a differential bigger than 2% is entered the system, all of the coordinators get a beep in their cell phones saying that there is a potential baby with congenital heart disease in whatever the place is, and we phone those places and ask them to check on these babies. And if the baby has been discharged, that is a lot of work to bring them back. So those adjustments really helped to make the protocol be followed more closely. But we can't stop thinking about a word of caution with this idea of universal indication of pulse oximeter testing in uncontrolled environments. We really worry that if we just pass laws, as it's being done very, very frequently now, that everyone should have a pulse oximeter test, but you don't have training of nurses, you don't have anyone to do a screening echo, you don't have a pediatric cardiologist available, you may actually have an enormous demand for babies to be checked without actually having the system set up for that. So perhaps one should think about setting up the scenario, clinically training people, having echoes available, training neonatologists, and doing a number of legal adjustments before passing a law to say that every baby should have a PO testing. A focused clinical examination was something that seemed to have much more impact, and in fact, 1 in each 2 neonates referred to an echo due to an abnormal clinical examination had a cardiac abnormality. We could ask, are they doing a better clinical examination after the training, or did we set up a structure that now allows for the neonatologists to have someone to help them when they suspect a congenital heart disease? Probably a little bit of the two things, but certainly it was very important to have retrained the groups into physical examination. The problem with that was that not all neonatologists were very careful with doing that, so there was some volume overload of a few of them. And then we have presented some results analysis showing the cases that have been missed, and then a bit of retraining, and that has helped. Clearly, level 2 screening was the most striking aspect of the network. The detection of congenital heart lesions in the state has changed completely, as we can see from this 10-year review of one large center, over 70,000 children, compared with the last 2 years of the network and compared with our own and other continents. Striking that in 10 years, not one single case of coarctation had been diagnosed. 8 cases were diagnosed in the first 2 years of the network, and similarly other lesions have reached international levels of detection. There were problems also with the screening echoes, mostly because, again, only a few neonatologists were involved, which led to overwork, and not enough equipment was available, and babies still needed to be transferred within Paraíba to have echoes done. Results review, trainings, and introduction of the echo taxi, whereby the machine goes to the child rather than the other way around, have been ways to ameliorate these problems. These are just examples of neonatal and fetal ultrasounds being done in the classical mode of the screening techniques. Now, for older children and for outpatient clinics, we had some 3 point of action events. 2 of these, which were called the Heart Caravans, happened in July 2012 and 2013 and took professionals to towns, seeing a large number of patients. Hard to describe in a few slides, but only those who really lived through it know the impact of being received in these towns, and taking videos, musics, making the children sing while they in the waiting rooms, and doing cardiology and echoes and nutrition, psychology, social assistance, nursing, a variety of different approaches to these children, doing training to the local teams in neonatal resuscitation and the use of transportation, and many others, having a support from the technical group. They were very important issues, and these caravans are something that we really want to continue and get better at doing, and seeing more children every time we go to these towns. These are the little patients that have been seen in the last caravan. So finally, operations. This is certainly a far bigger challenge. The numbers are still relatively small. Mortality is on 7.5%. They are covered We review data, and as I said earlier, we keep on online work collaboration throughout the intraoperative and postoperative periods. Our main limiting factor really is the number of beds, which we started on with 2 and increased to 3, but still a lot needs to be done in this area. This is surgical data, which I will not go in, some of the operations that have been done. Most of the children were older than 1 year, a few neonates, and mortality really was very much related to the RACs and the postoperative index score indexes we had. So in summary, these are the numbers of the full LIGA network for its 2 initial years. We currently over 65,000 babies have been screened. Our main limitations, we've realized that adherence is inconstant because of changes in nursing staff, not all neonatologists completely engaged. We're concerned with potential external interference. We must say that so far we have had none, but this is something that can change at any minute. And it's somewhat academically limited because it's run by busy healthcare providers, so data is not always recorded and processed as we would like, but a lot of clinical work has been done. We feel that the impact is very important through collaborative work, live and online. The network professionals have made early diagnosis and management of reality for underserved children in rural areas in the state of Paraíba. We have cut down on the number of transferals and in-hospital stays. For the whole period of the network, there has been no medical litigation. 87 professionals, nearly 100 professionals have been trained, and it had really shifted the medical practice paradigm in this state. We feel that the LEGO model is simple and it's malleable, it's adjustable to the realities of developing countries. It could be established in short time and at a relatively low cost. It can be replicated or adjusted to other areas of work. It certainly has knowledge transfer as its central part. Resources and knowledge of local dynamics are very important to have the network running, but certainly a degree of patience and persistence is also very important to achieve successful results. I cannot stop this presentation without saying thank you, particularly to the group that is coordinating this network and to all our partners within and outside Brazil who made this work possible. And to say that as October 2013 we have grown vertically and horizontally. We are now 22 maternity units, the pediatric hospital, and we have also gone into a full perinatology services. Our main challenges are sustainability and model expansion, which we will be tackling very strongly. So anyway, this was a summary I wanted to present. We realize it's a long journey, but hope to find the strength and support to carry on after these first steps have been taken. I thank you for watching it, and please do not hesitate in getting back to us to share your thoughts, to give us suggestions. These are our sites, email and Facebook, and we do look forward to hearing from you. Thank you very much.